All right. And I did figure out a new layout, so I should be able to see if anybody has questions. Feel free to unmute your mic or raise a hand either visually or via the app. Um, just double checking. Can everybody see the slides currently? Cool. Um, so after the last meeting, I asked for a little bit of feedback from everybody and kind of put together a list of things that I could do better. So one of the most consistent points that everybody was asking for was a little bit more discussion, a little bit more time for questions, either after the slides or just throughout. So I'll try to be a bit more mindful of that and try to give more room for discussion there. So you all know the study group. I think you three were all here. Yeah, all three of you were here last time. So we'll go ahead and buzz through this. First thing I wanted to do is just give group introductions so that you can all get to know each other and get to know kind of where everybody's working, what interests everybody has, and maybe we find some similarities. And then find some other people that you might want to network with later. Maybe you want to follow up after this call and get to know them, maybe partner on some research ideas, something like that. So for those of you who don't know me, my name is Matt, and I am an assistant athletic trainer with the Houston Dynamo 2 soccer team. I am in Houston, Texas, that if that wasn't obvious by the name. And then soccer is my primary sport assignment. I've worked with a host of different sports in the past, so I'm not just interested in soccer, but that's my current clinical setting. Let's go ahead and start with Dylan. If you want to just introduce yourself a little bit.
Yes, so my name's Dylan Medeiros. I am actually a physical therapist. I just graduated in December, so I'll be taking my board exam at the end of the month. So very excited to get my career underway. I do have a passion for sports medicine. I met Matt during my last clinical rotation. I was lucky enough to work with the Houston Dynamo down in Houston. So it was a great experience, and I see myself working in sports medicine later in my career after I get some more experience. So I think a good way to keep up with it is some of these meetings just to stay up to date with the latest athletic training, because I think there's a lot of back and forth between physical therapy and athletic training. They're very similar. So looking forward to learning some more.
Cool. One more thing that I don't have on these slides. Do you have any clinical interests, any injuries that you're specializing in or care to focus on in the future?
Um, as of right now, I'm really looking forward to just getting a broad understanding. And in physical therapy, we see a lot of low back pain. So any kind of weight bearing injuries, I think are really interesting because oftentimes the culprit is not actually the back itself. It comes from the knees or it stems from the hips. So I think if I can dial in my understanding of how those joints work, it can just make me a better clinician overall. So.
Cool. Isabel, we'll go to you next.
Hi, I'm Isabel Alvarado. I go by Izzy. I'm in Austin, Texas. I'm an outreach athletic trainer, so I mainly work within a school district with middle schoolers, and then I also help out at a D3 school here in Georgetown. It's like north of Austin. But yeah, I'm trying to get into the MLS world. So hopefully a few jobs will open up soon and I'll apply to those. But yeah.
Cool. Any favorite injuries? Anything that you geek out on?
I like anything with the shoulder. But at the middle school, it's mainly like knees and ankles. So yeah.
In the MLS, it's the same way.
Yeah.
Okay. Iris, if you want to introduce yourself.
All right, I'm Iris. One of these days I'll turn on my camera. Right now it's just not the time. So I'm still a student right now. I will be graduating in May. I am MAT student. I am doing my clinical site right now with Houston Dash. I've been here since August, so learned a lot. And my primary site that I wanna go into is soccer, but I'd be open to like college or high school when I first start off. Just honestly anything that will give me money to do what I like to do. Um, but injury wise, what I've liked learning has been like ACL recoveries and knees and ankles. So anything in that scope pretty piques my interest usually.
Sounds like you and Izzy need to flip spots. Okay, yeah, cool. I was definitely into ACLs when I was in undergrad. That was my kind of thing. We had a bit of an ACL epidemic, and we went down a rabbit hole with all kinds of different research and different testing that we put our teams through, and learned quite a bit. But at the same time, we kind of learned how little we actually know about the ACL complex, and so I went down that, like I said, I went down that huge rabbit hole and then came out the other side feeling like I knew nothing. So really good practice diving into something that deep. So if you're interested, I encourage you to do that, but just be warned that the other side, you might not feel like you have a better understanding. You might actually feel less competent than when you started. So, all right, cool. So let's go ahead and dive into this week's topic. So everybody knows this is fracture care. And the original intention when I created this topic was to fit within the month of January, was going to be emergency care. And so I was going to talk about kind of emergency preparedness for fractures, similar to what we did with cardiac last week. But the paper definitely took a bit of a different turn. It was a bit more surgical. I don't know if anybody read the paper this week, but a lot of the paper discussions were surgical implications and contraindications. So I will talk a little bit about the emergency action plan and the kind of splinting procedure, referral, emergency transport, that kind of stuff. We'll touch on that, but then we'll move into the kind of broader discussion that is fracture care. And I think, Dylan, you'll be able to chime in the later stages of the fracture care, especially the return to sport section. So that being said, all of these x-rays minus one are cases that I've worked on in the past. So if anybody has any questions, feel free to ask, and then I can touch on kind of what the case was, what kind of outcomes we had, anything like that. So again, I'll start with the overview, and kind of the way that I conceptualize fractures is the early stage, which would be the first aid. That's the immediate recognition and first aid provision for that. Like it might be an in-game or in-practice scenario. The middle stage, which then turns into surgical consideration. So once they've gotten either transported or they're getting x-rays, they're meeting with an orthopedic surgeon, those kind of things, discussing what the plan of care is going to be. And then the late stage would be actually implementing the rehab process, the return to play. Something that's important to consider with fractures is that they're not all the same, so you can't treat them all the same. So it's important to know the different types of fractures and different locations of fractures. And we'll dive into that pretty deep. Like I said, the paper basically broke down everything by specific fracture type. So we'll go ahead and start with the types of fractures. So the main distinctions or categories are open versus closed, complete versus incomplete, and then displaced versus non-displaced. Those are typical terminology for fractures. I think we're all pretty familiar with that. Is anybody not familiar with those terminologies? Cool. And then you can get really deep in the woods here. A lot of specialties within orthopedics will name different types of fractures. They'll have names that are categorizing them based on their shape. So you'll get like your spiral fractures, your oblique fractures, transverse fractures, that kind of stuff. Sometimes it's named by the cause, so like a stress fracture, for example, or it can be named by the body part. So a lot of times it's named like Colles fracture, for example, is always going to be a wrist fracture, and actually that's what this happens to be here. And then a Jones fracture would be another one that's obviously dedicated to a specific part of the body. But any questions so far? Pretty simple stuff for the most part, pretty straightforward. Locations of fractures. So obviously this is like anatomy 101. We learned the axial and appendicular spine back in like third grade. So within the axial, obviously you have your spinal fractures, your cranial fractures, your facial fractures. In this, I suppose they're including rib fractures. But then once you start to branch out, you start to get your pelvis fractures. Really, I mean, you can go a million different ways here, but upper and lower extremity is how the paper broke them down. So again, that's pretty straightforward there. But anybody see anything interesting with this X-ray? I'll give you a clue. It's the same person. Any takers? Any guesses?
Just
Yeah, I'll
looks
take
like
a,
there's like a lot of inflammation or something like around the foot ankle area.
Mm-hmm. Okay, Dylan, what were you gonna say?
I was going to mention the lateral malleolus on both sides. I don't know if it kind of looks like a horizontal fracture. I don't know if I'm just not reading it correctly, but it looks like something's going on there.
Yeah, so actually this was a gymnast that I worked with at the, what was it? It was the, I think it was like the national trials to go to the Olympics. And going down the tumble track, did like a double backflip and landed short. So when you land short, basically you jam your ankle up into dorsiflexion, and ended up having bilateral tib fib fracture. So really unique case. I'd never seen anything even remotely close to that before, but this was a pretty cool x-ray that I was pretty fascinated with for about a month after I saw it. So then talking about the actual notes here instead of going down memory lane, the early stage. So the first aid is the kind of bread and butter for athletic trainers here. You recognize the fracture. If you see any kind of displaced bones, feel any angulation, anything like that, you're definitely going to stabilize. And that's, again, pretty straightforward for most of us. The only kind of considerations on the back end of splinting, I mean, you can talk about, I suppose, the different types of splints. So from the gold standard, which would be like an air splint, a vacuum splint, then you can go down in quality and go to something like a semi-rigid splint, which would be like a SAM splint. Most of us are pretty familiar with that. And then I've actually seen in some settings where they don't have the budget for that, they'll use cardboard to splint. I was a Boy Scout when I was like 6 years old, and they taught us from a very young age that if you have a fracture and nothing else around, use like 2 sticks and then like a shoestring, and you can stabilize a fracture that way. Basically, you just need something that's rigid to kind of hold that bone in place. And the importance there is that if the bone is moving while it's a sharpened edge from the fracture, you have potential to damage soft tissue structures, whether that's an artery or a nerve, something like that. So that's the importance of stabilization. Bleeding considerations. The obvious one is if it's a compound fracture that's broke the skin. Now you have an open wound. You have to take your primary precautions there, your universal precautions, and depending on what kind of splinting you're using, if you have a vacuum splint, you don't want to get blood all over that. So for the most part, you're applying some kind of gauze, some kind of padding to stop the bleeding and protect your equipment, but then you're still doing the same application. You're splinting them in place. You're not trying to shove that bone back in through the skin. That would not end well. Any questions about splinting? Any hot topics that anybody wants to dive into with the different types of splints? No? All right. The other thing to worry about with bleeding is the compartment syndrome. So depending on the location of the fracture, if they have some kind of gross swelling, that's not the athletic trainer's responsibility. Most ATs are just going to send them via EMS. And then once they get to the ER, they're going to deal with that. But just being aware that once you recognize the fracture, time becomes critical, and recognizing that if an acute compartment syndrome is kicking in, you can cause nerve damage, you can cause necrosis, you can cause a lot of secondary damage there. So just being cognizant of, you can't sit around it forever while you try to wait for splinting. You got to get them out and go. Stress management, I think, is an important thing to consider with athletes. A lot of times they see these gross angulated fractures and they look down and they they freak out. And so keeping them calm and composed, obviously keeping yourself calm and composed, I think it's an important consideration here for the athletic trainer. I think it's obviously a moment of high stress for everybody involved. The coach is going to be on edge. The players are all going to be on edge. Anybody who sees something that is that traumatic is going to freak out. So kind of keeping control of the scene and letting everybody know that you have it under control kind of helps things to calm down. So just being aware of your own emotions as you approach a situation like that. Transport EMS versus non-EMS, pretty much. I mean, you can transport anything via EMS if you're ever unsure. But for the most part, you can transport a lot of fractures via like if you have another coach that's in the area that can drive them, or a parent. I've sent, like when I was working with youth soccer players, I've sent several kids with fractures, splint them, and then send them in the backseat of the car, and their parents just drive them. Really, the only times I'm activating EMS is if it's some kind of long bone, like a larger long bone, like a mid-tibial shaft, a femoral fracture, something where it's an obvious angulated large bone, where they're likely to have bone displacement, they're likely to have bleeding, they're likely to have acute compartment syndrome or nerve damage, artery damage, anything along those lines. That's pretty much the only time I'm sending them via EMS. Any questions about that stuff? Did I get anything grossly, dramatically wrong?
Yeah,
Cool.
just a quick question. Circling back to stabilization, you had mentioned like how patient in determining if there's any angulation of the bone where there shouldn't be. But what are other signs and symptoms you look into to determine if it's really a fracture or if it's more of like a soft tissue thing that they got going?
Good. It's an interesting question. I think a lot of times it's assumed that like athletic trainers we're just natural at recognizing those things. So like when you approach a scene, you're already starting your primary survey. You're looking at them. How is the athlete presenting? Are they rolling around? Are they walking? Are they standing? I mean, if it's upper extremity versus lower extremity, for example, if they're walking, it's probably not a fracture. I mean, there are cases where they can be weight bearing, but if it's an acute fracture and it's like a mid tibia with some kind of displacement, if it's like a complete fracture of the tibia at mid shaft, I promise you they're not weight bearing. And so some things you're looking for would be, I suppose, like the athlete's response. How in pain are they? How emotional are they? I would say you're looking for kind of movement. Are they rolling around on the ground and holding that thing up in the air as it's flopping around all over the place? Or are they stationary? Are they I don't want to move this thing because I know it's going to hurt, something like that. So you kind of read the room there. There's no like textbook answer in terms of this is exactly, if I see this, I know it's a fracture. If I see this, it's not a fracture. But the other thing I think that I use to kind of aid my decision there is knowing kind of the sport and the risks of the sport. So for example, a gymnast is never going to just run down the tumble track and then like fracture on their way, like as they're taking their first step. You know that moment of high force is coming as they land on the back end. So you position yourself there, you see, did the landing look normal? Did the landing look awkward? Did they just collapse when they landed? They didn't even catch themselves because their bone just collapsed underneath them, something like that. You're watching for the play. You're seeing, okay, did that look like a really awkward moment of high force that could potentially cause something? Impacts would be another thing. Collisions in sports like football or in soccer, for example. I've got a mid-tibial shaft image or x-ray later in this presentation that was a goalkeeper who came out for a ball and a kid basically ran straight through his leg while it was planted. So You kind of see the play coming and you can anticipate when an injury might happen. And then when you get out there, you're looking for, okay, does everything look like it's in the right place, facing the right direction, that kind of stuff. Does that help? Cool.
Absolutely. Yeah, that makes a lot of sense. Thank you.
Any other questions?
Just like from my personal experience, Dylan, I think another thing that kind of helps like in detecting fractures is just like swelling and like how quickly the swelling like happens. Because like with most fractures, like they swell up like immediately. If it's like, oh, I hurt myself and then like a day later it starts swelling, most likely it's soft tissue. I've probably splinted at least like 10 kids like at the middle school setting. And I would say like maybe 8 out of 10 of those, like there was like immediate swelling. And when you're palpating, like normally with fractures, like it's very like localized, like they can usually like point to the spot versus like soft tissue, they'll be like, it just kind of hurts here versus like right here, if that makes sense.
Yeah, that makes a lot of sense. Thank you for adding that.
Yeah, I agree. That's 2 good points. Definitely the immediate swelling. There are a few other injuries, pathologies that can cause instant swelling. ACL would be one. But again, you're kind of watching the play. Does the mechanism of injury make sense for an ACL or does it make sense for a fracture? Obviously, they're going to have different presentations. So a non-contact, I'm probably going to assume ACL. If it's a contact, say they jump up to catch a ball and somebody takes their leg out and they land awkwardly on one leg, I'm probably thinking fracture. The location of the swelling would indicate that as well. So that's swelling is a great point. This is the X-ray that I sadly had to steal from the internet. I had a really cool X-ray when I was at Camp Woodward. There was a roughly, I would say probably like 13-year-old who went off of, they called this giant ramp of dirt. They called it big dirt. So there's big dirt and small dirt, which are basically just describing the size and the texture of the ramps that they were going off. And they went off of big dirt and landed on an outstretched arm. Well, when I responded and I got there, I was palpating and kind of felt some deformity. I felt the clavicle, pretty typical like piano key sign where it's elevated. It's obviously displaced, but I couldn't quite tell, was it like an AC separation and the whole clavicle is just elevated, or was it a fracture and the fracture is what was angulated there. So we ended up getting the X-ray back, and we didn't know this at the time because the patient was just hysterical. And after getting the X-ray back, we realized they had already had one clavicle fracture, had a plate put in, and then refractured at the very end of the plate. So when I was palpating, I wasn't really feeling any sharp bone. Nothing was really going to poke through the skin. And what I was feeling was the end. It was a rounded end of that plate. So a really cool story in terms of presentation. And then the X-ray was so cool. I hope one day I can find that X-ray again, but sadly I don't have it. So got to track down the archives somewhere. So that brings us to the middle stage, and all kinds of different considerations that surgeons are going to bring into the mix. A lot of times athletic trainers won't have a say in this, but if you are involved in the surgical process, it helps to know what your options are. And so what are you going to do for the immobilization? Are you going to have them immobilized via a cast? Are you going to have them in a splint? What kind of things are you going to consider when you're having that conversation with the orthopedic surgeon? Are you going to do a closed reduction to realign those bones? Are you going to fixate the bones, the ends of the bone, so that the bone is stronger and it heals better? Are you going to go in and then have surgery to, if it's a damaged joint? Are you going to have to do a bone graft and do a bone plug to promote healing via strong bone tissue from another location? Those are all kinds of different considerations that orthopedic surgeons have to do. Obviously, that's a bit outside of our scope, but it can improve your outcomes, especially depending on your sport and if you're dealing with a competitive or professional setting. So we all know that competitive athletes have a lot of money involved with them, and so time loss is a big factor in decision making. So if somebody's considering should we fixate this bone or not, and if fixating gets you back in return to play, say 6 weeks sooner, that could be the difference between making playoffs or not making playoffs. So some important considerations, because you could have an orthopedic surgeon who's going to say, yeah, we won't do it, we won't fixate it, but then you could bring some evidence and say, well, actually for this body part, the evidence suggests that it's actually a faster return to play with good outcomes if we go ahead and do some internal fixation. So just things that ATs I think should be aware of, not necessarily be an expert in, but just kind of be mindful, like these are some different options. Questions there? We'll talk more about the different types of treatments and the different applications of these different things for various body parts when we get into the paper, because the paper dove deep into this stuff. But for right now, I just wanted to give a bit of an overview of the different options. So then late stage, and this is again where a physical therapist is probably going to specialize in the rehabilitation process, the kind of longer term considerations. You're worried about some kind of, once you've got the wound already healed and the surgery's already been done, now you're worried about, well, what's the risk of infection? What is the presentation of a osteomyelitis bone infection? What does that present like as opposed to a typical skin infection? How long are you going to wait to determine if the bone is healing? How are you tracking if that bone is healing? So if you've got a malunion or a non-union, how are you going to determine that later down the road if you decided to go with some kind of a conservative treatment process? And then ultimately that leads you down the road to the rehabilitation, the load management. This chart I've seen presented a few different places, but basically the kind of week by week progression and the appropriate loading, the dosages. One scheme that I've seen that's very easy to remember is the 50, 70, 80, 90, and then you can get them back into a typical training week. But so all you're doing there is taking whatever your metric is and say it's like total distance, for example. If in a typical week they're going to run, let's say 10,000 kilometers, you would want to start them off somewhere in the 5,000 kilometer range. And then you're going to obviously monitor that response to that 50% load and see, are they responding well to it or are they responding poorly to it? If they respond well, then you can progress up to 70. It's a bigger jump in that earlier stage because it's such a small dosage. Their body should be able to respond pretty quickly to it. And then the jumps get smaller and smaller as you get closer and closer to 100% load because it's a lot more stressful to the athlete. So again, that's just one simple way of remembering and kind of mapping out, okay, well, if we've got 4 weeks until they can return to sport, I'm going to start them at about 50%, and then I'm going to go to 70, 80, 90, and then by that point, they should be pretty close to getting back into the mix of things. Any questions there about the chart, the load management, anything like that?
I just want to add, I really love this. I really love this graph because it demonstrates the principle of progressive overload really well, and I think it's cool how this definitely applies to fracture and management of a fracture, but it also applies to soft tissue injuries as well. You know, start them low and slowly progress their load as you're able to tolerate it. So I think you explained that really well.
Yeah, it's interesting. There's actually a bit of criticism around this. This was put out in 2016, and then there was actually another kind of response that was critiquing it that was put out, I believe, 2019. And they aren't sure that the numbers, so the ratio that they're trying to figure out is the acute to chronic workload, and that is basically taking what they've done for the past. Again, the numbers kind of fluctuate here and everybody uses it a little bit differently, but it can be somewhere between 3 to 5 weeks in the past, and you see what they've done. So then if they've done an average, let's say they've done 3K, 2K, 3K, and then their average is, let's say 3K. So then you want to map out, okay, well, what would their next week take them to as an acute spike? So if that is more than 1.3, or 1.5, sorry, then obviously you're getting into that danger zone of where they're likely to get injured. And that they provide some statistical evidence that is likely. It's correlated with a higher injury risk in return to play settings, but it's not 100% guaranteed. And their kind of ratio, like the way that they formed their calculations, is a little bit arbitrary. I still apply it in my return to play settings, but it's not a perfect science. There are some flaws there. All right, so then that brings us to the paper. So this paper I thought was really interesting. Obviously, it's really current. And a lot of the ideas here are kind of reviewing older concepts that we took for granted throughout orthopedic care. And basically the optimization of this care. And so the paper broke it down into the 5 most common upper extremity fractures and lower extremity fractures in sports. So really relevant info for us because we need to know, like, okay, we're likely to face these things. So the paper pointed out that upper limb fractures accounted for 75%, 3/4 roughly, of all sports related fractures. So kind of keeping that in the back of your mind as you're approaching some kind of a survey. So if you go out onto a field and you see somebody down holding their wrist, okay, well, that could very likely be a fracture. It could also be a sprain, but you're worried about a fracture in your evaluation. You want to rule out that fracture before you put somebody back into the game. And then within the upper extremity fractures, you've got the finger phalanx, which is typically a non-displaced or a minimally displaced fracture. So you don't really have to do too much with these. And the care for these doesn't really vary too much from athlete to non-athlete. The return to sport is pretty quick for the most part. You've got a ton of circulation in the hand. So as long as you can get full range of motion, full grip strength back, things like that, they should be able to jump back into non-contact sporting environments in about 2 to 4 weeks. But then obviously you want to wait for full contact. You run the risk of damaging that impartial healing. So you want to wait for that to be about that 6 to 8 week window. And depending on your sport, you might want to wait even a little bit longer than that. For football, I would probably be a bit more conservative just because their hands get beat up so much. In soccer, you can be maybe a bit more aggressive because the only real risk of a refracture would be if they fall and they catch themselves on that hand. So taking into consideration which sport you're working with, that can help you kind of guide that return to play process. The distal radius, this is primarily treated via current conservative treatment, but you can fixate if you're concerned about a non-union or a malunion. So a lot of times with sport, obviously you're sitting around waiting for that bone to heal so that they can get back into sport, and you're probably doing follow-up X-rays to see, is that bone truly healing. One of the issues with doing conservative treatment in the distal radius is you sit around and you wait for, say, 4 weeks, and then maybe it does, maybe it doesn't heal. So after 4 weeks, okay, well, it's not healed yet, so let's keep waiting. So then you wait another 4 weeks, and then maybe it's still not healed. And you can wait a long time. You can waste a lot of time sitting around waiting with conservative treatment. So the suggested process for this injury within that paper is to do the fixation. And they talk about it a little bit later in one of the cases, the 6th and final case that was presented on this paper. They gave a case study of why it was important that they did the early fixation and how they were they were able to return to sport early because of the fixation. So something to consider there, especially, again, knowing that you're going to see a distal radius fracture sometime in your career, considering, well, the traditional treatment practice is conservative because it tends to work well, somewhere in the 90th percentile is conservative treatment. But if you're working with competitive athletes, you might want to expedite that process. You might not want to risk wasting time. So you're just going to go ahead and do that surgery and then go on from there. The next one that they talked about was the metacarpal. And again, usually conservative here. It depends a little bit on the area. So The thumb tends to be a bit more problematic. Obviously, the thumb is a lot more mobile than the rest of the fingers. So if you have some kind of a intra-articular fracture or a thumb fracture, then you maybe want to look at a fixation process here. But for the most part, these heal, again, and anything in the hand has got tons of circulation. It's going to heal pretty well. And as long as they're in a non-contact, they can run without real risk. Obviously, they could potentially trip and fall. They could sneeze and hit themselves in the face or something weird like that. But the likelihood is that they're not going to get injured by doing non-contact training. So if you can get them back in a non-contact, you can start that as early as 1 week. And then you can jump into full contact somewhere in the 1 to 4 week range. They did suggest that if you go as early as 1 week, that you acknowledge the risks with your athlete and you discuss those thoroughly. Obviously, with impartial bone healing, even if you fixated it, you're running a risk of either a refracture or damaging the structure of the screw or the internal fixation. So just being aware that yes, it is metal, it should be stronger than bone, but they're not impossible to break. It happened before. So being mindful of that. The clavicle, they do a lot more surgical cases with clavicular fractures than non-athlete clavicular fractures. So one of the reasons they said this is the case is because the refracture rate is a lot higher in athletes, and because they're using their shoulder so much, they're moving so much, they're using their arms very aggressively. That mobilization and mobility, it really leads to a lot of stress put on the clavicle. And that's something that we don't really consider on a day-to-day basis. But if you have a clavicular fracture, then you know how painful and how frustrating it can be because you have symptoms for a long time after the bone heals. And so surgical fixation here allows athletes to not only get back into sport faster, but it reduces symptoms a lot faster as well. So for athletes, they do suggest doing internal fixation for the clavicle. Typically, again, that's done with a plate. But as I saw with the BMX biker, it can be refractured. You can actually refracture that clavicle even if it's already been fixated. So the last one they discussed in this paper was the scaphoid. I think most of us know that the non-union rates are a lot higher in the scaphoid. This tends to be because of circulation issues. And that is why a lot of times they will suggest the scaphoid to be fixated. It also decreased the return to play time. So on average, it was somewhere around 6 weeks after doing surgery and 15 weeks for conservative treatment. So you can see, I mean, especially in that professional environment, you're looking at a time loss of an extra 9 weeks. That is half of the NFL season. So if you're working with professional football where these guys are getting paid probably, I don't know, $500,000 a week, you just wasted $4.5 million because you're sitting around waiting for that thing to heal, and it might not ever. So with athletes, they do suggest fixating pretty much all scaphoid fractures. For that, they can return to sport, or they can return to non-contact somewhere in the 1 to 2 week range, and then do a full return somewhere in the 6 to 8 week range. A lot of times you're going to, with conservative treatment, you have to have them immobilized. So you have to have them either in a cast or a wrist brace. But with a surgical fixation, you eliminate that need. So after you do the surgery, that's another benefit, is you don't have to have them in a brace or a cast. They can jump back into sport a lot sooner because they don't have to wear that. Any questions about the upper extremity? I know I went through a long ramble there. Any questions about the specific injuries or any conflict? Anybody ever seen any of these fractures before? Iris, have you seen any of these fractures since you've been with us?
Not with the dash, but back in Tulsa. I go to the University of Tulsa, by the way, everyone. Back in Tulsa, I saw a couple clavicles at the high school level. And I played indoor soccer over there, and a guy broke his his clavicle, and I was like, "Yeah, you need to go to the emergency room right now." And he's like, "Are you sure?" I was like, "Yes." I took like one palpation of like both of his clavicles. I was like, "Yeah,
Yeah,
you need to
they're pretty
leave."
gnarly when you get them.
Yeah, it was very like obvious. Like it was more obvious than I thought it would be.
Mhm. With the high school students that you saw the clavicular fractures with, did they end up having surgery or did they do conservative treatment for that?
Um, I think at the varsity level, one of them did conservative, and then we had a lot of middle school, and they were all surgical. But the
Gotcha.
high schooler, he had, I think that was like the third time he had broke it.
Hmm.
So he just decided he just didn't want to go through surgery again.
That's probably a fair consideration. I don't know if I would want to do a third surgery if I had already done two failed surgeries. So,
Yeah.
I think that might be my cue that it's just not meant to be if you've fractured the same bone 3 times and had surgery twice. Cool. So then we'll get into the lower extremity. Is that helpful information or am I rambling too much? Give a thumbs up if you want to keep going, thumbs down if you want me to just move past all this. All right, cool. So the lower limb then, by contrast to the upper limb being accounting for roughly 75% of sports-related fractures, is then 1/4 of sports-related fractures. And these are the 5 most common. So the ankle, the metatarsal, the toe phalanx, the tibial shaft, and the fibula. So I have seen the tibial shaft, and that X-ray is coming up at the end. But really cool X-ray, really gnarly presentation, but really scary at the time. So again, kind of cool learning moment, but it's one of those things where it's like you are freaking out in the moment, and then you look back at it and you learn so much from that case. So for the ankle, this was a case where surgery actually decreases a lot of the outcomes. So it slows down the return to play time. You have to be very conservative after surgery for ankles, and that's usually because they're non-weight bearing for such a long period of time. Particularly in like syndesmotic surgeries, if you're having a high ankle sprain, that's if you're doing, regardless if you're doing the screw or the tightrope mechanism, you're non-weight bearing for usually somewhere in the 8-week range. And that really pushes back your return to play time. So something to consider there with the return to play, depending on where you are in your season. If they're going to be 8 weeks to walk, a lot of times that can take them up to 20 weeks to do a full return to play, as opposed to non-surgical, where you can do successfully start walking around 6 weeks. You could do contact somewhere in the 12 to 16 weeks, and you could be back into full participation by the end of that 16th week. So it adds about 4 weeks, according to this paper. So, and then the other thing is that a lot of these ankle surgeries end up still having symptoms after the procedure is done. So they're complaining about pain, they're complaining about stiffness, they feel like they can't move as well. They have a lot of complaints after these surgeries. And so this paper actually suggested that the surgery is most common, but the symptoms, out of the symptoms especially, so this was a statistic I wrote down, was for the surgical group, they had 71% of their patients complain about symptoms post-surgery. So that's that's the bulk of your cases, versus only 17% for the non-surgical. So obviously that cuts that down quite significantly. And again, with the time extension there, I would opt for most ankles, as long as it's stable, it's non-displaced. I would opt to do non-surgical for most of those ankle fractures. The metatarsals, obviously the 5th metatarsal is the kind of most notorious because of the low blood supply there. And you can get stress fractures, you can get Jones fractures, you can get avulsion fractures there. So depending on the site of the metatarsal fracture, this paper talked specifically about the Jones fracture primarily. And the screw fixation is the most common treatment here, and it has good surgical outcomes. The concern with the Jones fracture and the low circulation is the same as the scaphoid. You have a high risk of non-union. So if you go conservative here, About 67% of their cases have non-unions. So that means you're going to end up having to go back in and get surgery anyway. Versus 95% have a successful union if you go surgical. So it improves bone healing. You can usually get them onto their feet a little bit sooner, and it strengthens the bone quite a bit. So they're a lot less likely to refracture if you go with the screw fixation here than if you go conservative. So I would pretty much always suggest somebody go surgical for a fifth met fracture, depending on obviously the location and the individual's anatomy. But for the most part, you're going to go surgery with a fifth metatarsal fracture. Toe phalanx is pretty much the same as a finger phalanx. It's a little bit more concerning because you're weight bearing through it, so you can have a lot more symptoms with it. But for the most part, these are non-displaced fractures that are stable, and you can't really screw them up too much. You can get displacement if you keep running around on them, but after about 3 or 4 weeks, you can start to walk. And then from there, it's just a progression of return to play. And that can take somewhere in the probably 3 to 4 week range, depending on how aggressive you're being. Tibial shaft. This is probably the most complex of the lower extremity fractures, at least presented here. A femoral fracture is probably more complex, but it's not very common. Primarily going to be surgical fixation here. The success is a lot higher, the return to play is a lot faster, and the symptoms profile is a lot better. So pretty much everything gets improved with surgical fixation of the tibial shaft. And just if you're interested in the numbers, the return to play for a surgical case is going to be somewhere in it's a really broad range, but I think that's kind of indicative of what the anatomy is that you're dealing with. You load so much of your body weight and you're forced through that tibia. So the range they gave was somewhere between 12 and 54 weeks for a full return. If you go conservative, that range is just as big, if not bigger. And it goes from 28 weeks to 182 weeks. So that is a very wide window of return to play time. But imagine you're telling this athlete, well, if you don't do surgery, you'll get back somewhere between 28 and 182 weeks from now. That is not very helpful. So half a year to 5 years, if my math is correct. No, 3 years. But yeah, so I would probably always opt for surgical here, especially with athletic population. You're going to be non-weight bearing for some period after the surgery, but your total return to play gets a lot shorter. Fibula fractures are pretty much the opposite. Because you're loading most of that weight through the tibia, the fibula doesn't absorb as much of that force. And so this can usually be a conservative case, and typically that bone is going to heal in the normal time frame, which is very like stereotypical textbook 6 to 8 weeks. You've got normal blood supply to the fibula, and again, it's non-weight bearing for the most part, so you can be a bit more aggressive here and be conservative, and they usually have good outcomes. The considerations that they kind of pitched, or the questions that you always have to ask yourself, and I think again, this is obviously like the bread and butter for an orthopedic surgeon. This is what they do for a living. But for an AT who's going to influence this, maybe you're talking with a parent if you're working with high school or youth athletes. Maybe you're talking with the athlete themselves if they don't feel comfortable with that surgeon. Maybe they're coming to you for advice. These are the things you have to talk through with them. Should you do surgery? Should you not? If you're going to do surgery, which method of surgical fixation are you going to do? If you do the surgery, what's the immobilization period look like after the surgery? How long are they in a cast? How long are they in a brace? How long are they in a splint? Whatever it might be. And then the last thing, and this is probably the most important thing that everybody wants to know. The coaches want to know when they can get back. The athlete wants to know when they can get back. Anybody in a front office that's in a professional sport wants to know how soon can they get back. You have to know the timelines, and you have to know the pros and cons of every surgery that you're working with. So I would always encourage you to have these conversations anyway, either with the orthopedic surgeon or with the athletes. But it's just, again, it will just make you that much stronger of a clinician if you're actually aware of these things, instead of always defaulting to the surgeon who may or may not be considering the various factors that you have to consider. Any questions, any comments here? Anybody want to chime in? I've been ranting for a long time, so feel free to take it away.
Yeah, I'll just mention. I thought it was kind of interesting when I was reading through the article. It seemed like the only fracture that had worst outcomes with surgery was the ankle, and it's just very interesting to me. I'm not entirely sure why. Do you have any idea why that may be?
I have a few thoughts, but I'd rather pass it around the room. So, Iris, what do you think? Any thoughts? Any guesses?
Um, honestly, I'm gonna just. I think it's mainly like the complexity and the how the ankle sits. I feel like it's kind of hard to replicate once it's broken. Um, I feel like the natural like curvatures of the bones is kind of hard to replicate. That's like mainly where my mind goes when I think about it.
Yeah, definitely. That mortise is definitely a complex structure. You've got a lot of small structures that are passing in and out of that. So, I think the individual anatomy is definitely an important consideration. Izzy, what do you think?
Um, Mainly working with like middle schoolers. I haven't seen any surgeries mainly because usually like 99% of the time when they fracture their ankle, it's like a growth plate fracture. Um, so most of the time they're just like either in a boot or a brace. And then, yeah, I know like with a lot of surgeons, obviously, because the growth plate's open, they don't want to disrupt that. So that's the main thing that I've seen. But I guess for like adults, kind of the same thing that Iris is saying, but also I feel like usually the fibula is more so fractured than the tibia. And since it's not really so much of a weight bearing bone, I feel like that might be the reason why surgery would be like a worst case scenario. I don't know if that makes sense.
Yeah. I mean, I don't have, again, I don't have like the answer. The paper doesn't discuss it like that thoroughly. They don't say why it is the way that it is, but I'll take my stab at it just like everybody else did. I would assume there's a lot of implications with not only the anatomy of the ankle, but also like the biomechanics of the ankle. Think about how much movement is happening in the ankle. Any small degree, if you lose, I mean, say you have an ankle sprain, right? Like if you lose 2 or 3 degrees of dorsiflexion, you notice that when you're out there on the field or out on the court, you're playing. And so if you throw off the kinematics, the dynamics of the ankle, the interaction between either the tibia and the fibula, or maybe it's the tibia and the talus, something like that. If you're messing with that range of motion at all, there's so much that changes up the kinetic chain. So if you say you lose 2 or 3 degrees of dorsiflexion, now does the knee have to bend an extra 2 or 3 degrees, or is it magnified? Maybe they have to squat even maybe 4 or 5 degrees now with the knee. What does that then do to the hip? So I think there's a lot of kind of kinematic problems that can arise from it being an ankle. The other thing that I was kind of thinking is that it's a bit of a nervy area, similar to like the shoulder and the hip. If you have some kind of nerve that's passing through a tunnel, or the wrist would be another good example. If you have a nerve that's passing through a tunnel, maybe you're going to get a lot more symptoms from it. And obviously, we know that symptoms drive a lot of our outcomes. If they feel pain, or if they feel some kind of a tingling or a numbness, if they feel like maybe they don't have the motor recruitment because there's a nerve involvement there. I think there's just a lot more risk there because of all the structures that are kind of passing through there. So that's my take. And particularly they talked about the syndesmotic surgeries. I've seen a couple of them in my career. I'm not an expert there, but the ones that I've seen, they tend to lose just a tiny bit of dorsiflexion, and it'll take them a long time to get that back. And the whole time they're trying to, I mean, it's safe for them to play, right? Like their ankle is stabilized. But they continue to complain of symptoms. They say, my ankle just feels stiff, or it feels like it's locked, something like that. So I think it's just subjectively, I think it throws another kind of fork in the system there. That help give you some ideas to kind of play with or chew on?
Yeah, absolutely. I think that makes a lot of sense, especially with the ankle being a very mobile joint. It makes sense as why, if you disrupted some of those structures during surgery and you throw off those kinematics, why the outcome could potentially actually be worse. So that's very helpful.
Cool. So I believe then that brings us into the special considerations. And again, they gave case studies at the end here. So pretty much just picked 6. I don't know if there's a rationale for how they picked their 6 cases, but went through 6 of the 10 important surgical considerations of the upper and lower extremity here. And so for the clavicle fractures, fixation allowed them to get to an early return to play. Ankle, they had an ankle fracture that was better with conservative outcomes, and they had a lot better symptom profile. They had a scaphoid fixation that allowed, again, for early return to play. You'll notice a trend here with these surgical cases. They had a tibial shaft fracture that had fixation that allowed for earlier return to play. They had a Jones fracture fixation, which helped with the union rate. And then they had a distal radius fracture that they improved their kind of prediction or confidence that the bone would heal via the refracture rates. So they went with the surgical fixation there as well. This is the tibia fracture x-ray that I was talking about. And so this was a goalkeeper who came out of his box, ran way out, like close to midfield, and collided with one of the attacking players, came in with studs up, and just kicked him basically right mid shin, and then basically went straight through the tibia. So obvious displacement. The kid was in a ton of pain. When you see these, they are not calm. They are freaking out. And so a lot of emotion there. Because it was youth sport, the parents were involved, and because it was displaced, we ended up we used the air splints. It wasn't a compound fracture. There was no blood involved, but this would be a location where you're worried about, like, in a compartment syndrome. So this would be another case where even if it's not that far displaced, maybe you can't tell. But it's a fracture, you're probably worried about some kind of a compartment syndrome here. So you might want to just send them via EMS either way. But you can see here the mid shaft fracture, but then also up at the top, you can kind of see a little bit of the growth plate that you were talking about, Izzy. Probably the starting point of some Osgood slaughters there. But it's just kind of a cool x-ray you don't see every day. So in summary, each type of fracture is a little bit different, and each location of the fracture is a little bit different. And these kind of things influence the decisions you're going to make. So keeping in mind the percentages of successful surgeries versus unsuccessful surgeries, what are their symptoms like, and what's the time of their return to play. So basically 3 considerations: symptoms, time, and outcomes. I tend to categorize these things into 3 stages: early stage, which is first aid, primary response, middle stage, which would then be the surgical considerations, and then late stage, which is the load management. So that is the end of the meeting for this week. Thank you all again for coming. Hopefully you were able to get more out of it this time with a stable internet connection. And then next week's meeting will be emergency transportation, talking a lot about the kind of referral process, which types of hospitals you're going to send them to, which cases should be sent, which cases shouldn't be sent, and a lot of recognition of emergency scenarios via athletic trainers' perspective. Any last comments, questions about fracture care? All good?
I had a weird tibial fracture for a middle schooler at a track meet like 2 years ago. He went to go do a high jump, and I guess on the leg that he was jumping off of, he had like an avulsion fracture, but his tibia, like, it at least felt this way. It like fractured like straight through, like on the proximal end. I didn't see it when it happened, but they called me over and he was just like holding his knee. And at first I didn't know what was going on because like he was holding it, didn't want me to touch it. But then when I went to move him, he started screaming and I could just feel like his leg just like hanging. And I was like, okay, I got to stabilize. So I held his leg, and for some reason, EMS took forever to get there. So after a while, like my arm started shaking because I was holding like dead weight. And it was a big kid. And he's like, oh, my leg is shaking. I was like, no, that's my arm that's shaking. So I had to get some of the coaches to help me like stabilize him. And then, yeah, EMS came and they splinted him. And yeah, he was out for like the rest of the year. It happened in March, so he was out. And I felt bad for him because he had just gotten like cleared because he had ACL surgery on the other leg. And yeah, that happened. So yeah.
That's definitely a weird presentation. I'm not familiar with any avulsion fractures of the tibia. I'd be kind of curious to know what was the case leading up to it, or if there was anything there, or like a stress fracture that had led to it.
Yeah, he
But
had been complaining of like patellar tendonitis type pain for like a couple weeks before then, and then that happened. Yeah.
Got it. Was it at the tibial tuberosity then?
Yeah, it was like around there. I didn't
Okay.
get like an
Got
X-ray
it.
or anything.
Yeah.
But yeah.
Got it. Got it. Yeah, that makes a lot more sense. So that's probably very similar to like an Osgood with just a displaced fracture there. The point I wanted to make in reference to last week, we were talking about with the cardiac emergencies and running through the timing of your EAPs, right? That's a tribute here to really going through the timing of those things. You were thinking, oh, in my school, I had to stabilize for like maybe 30 seconds to a minute, and then all of a sudden EMS is magically there. Well, depending on which city you're in, you said you're in Austin, right? Like that's a big city with a lot of traffic, and maybe I don't know where the location of your school is, but maybe you're a long drive for that EMS, especially when you're out in like rural cities or towns. A lot of times you're even further away. Maybe you're an hour from the closest hospital, and so that's another consideration to make. Well, if it's going to take EMS an hour to get to us and then an hour to get to the hospital, maybe it's faster if it's as long as it's safe for them to transport. Maybe you just splint them and you just drive one way so that they only have to wait an hour to get into the ER. So yeah, again, timing of EAPs is very important, including with fracture care, and then including the EMS in your EAP, letting them know, okay, this is where we are. Roughly how long do you think it'll take to get to us? And then you can be aware of that. Well, if I'm going to have to stabilize this kid's leg for 35 minutes, I'm definitely going to position myself a lot different than if I have to do it for 3 minutes. Cool. All right. Well, thank you all for being here. I hope you were able to get something from it, and I will see you all hopefully next week.